Good evening all. Today we'll discuss a brief topic which is electrocardiogram in chamber enlargement. I think this is the most basic topic in electrocardiography after axis determination, that which are the various chambers which are enlarged. We can know the chamber enlargement first by your ECG. Then you can also know the chamber enlargement in your X-ray. We have various criteria. And then finally, we know the correct thing in our echocardiography. But how do you say which chambers are enlarged in electrocardiogram? There are various methods and there are various criterias. I'll try to cover the important points in each of them. We'll go via a case-based approach. Now, this is the ECG of a 40-year-old male with paroxysmal nocturnal dyspnea. As you all know, PND is a sign which is very sensitive for left heart failure. So if there is a PND, then definitely there is evidence of left heart failure. Now, this left heart failure can be due to any disease. Let it be ischemic heart disease, valvular heart disease, cardiomyopathy, or sometimes very rarely some congenital heart diseases. And very rarely pericardial. Pericardial diseases mostly present with right heart failure, we know. Now, if you see this ECG, once again. Yeah. So if you see this ECG, the important thing we should know about a ECG is to tell whether it's a sinus rhythm or not. So to tell it is a sinus rhythm, we can see that each P wave is followed by a QRS and the P in lead AVR is negative. So if this is the thing, then we can tell that this is a sinus rhythm. Now you have to see the morphology of P waves. You see the morphology of P waves in lead 2. There is a bifid P wave, and this bifid P wave suggests that there is some definitely evidence of left atrial enlargement. A bifid P wave in lead 2 always suggests a left atrial enlargement. Also, if the duration of this P wave is more than 120 millisecond. So this P wave looks like around 120 millisecond. And the third criteria to tell that there is a left atrial enlargement is you have to see the two peaks. You have to see the two peaks of the P if you are able to see, and if the duration between the two peaks of the P wave is around 0.04 milliseconds. So these three things tell that there will be a left atrial enlargement. These are few of the criteria. Then we also have something known as the Morris index and the Macruz index. I'll discuss in the further slide. Now, if you see the lead V1, you see the lead V1, there is a terminal negative deflection. So a terminal negative deflection in lead V1 is always almost suggestive of left atrial enlargement, though there is exception we'll see in the next slide. But if you see a V1, which is a P wave, is a negative deflection, it is known as a P mitral. So it is also known as the Morris index, which again I'll come in the next few Macruz index, sorry, and the other one is the Morris index, which I'll come in the next few slides. So this ECG is suggestive of a left atrial enlargement. Now this left atrial enlargement can be because of various things, but the patient has PND. It means that there is a significant LV failure, which can be because of a mitral stenosis or because of any other mitral valve disease, dilated cardiomyopathies, or ischemic heart disease, or a hypertensive heart disease. So these are the various things we have to keep in mind. So next we'll go to another ECG of a 55-year-old gentleman with a history of class 3 NYHA dyspnea. We know that NYHA is class 1 to 4. Class 4 means at rest dyspnea. 3 is more ordinary physical activities is causing dyspnea. So this patient has a class 3 NYHA dyspnea, and if you see, this is a sinus rhythm. But if you see lead 2, as compared to left atrial enlargement, here the lead 2 is significantly tall. So it is also known as a P pulmonale, where the lead 2 P wave is more than 2.5 mm, and in lead V1, when you see the P wave, it should be more than 1.5 mm. So that is known as the P pulmonale. But what is more striking apart from that is this patient has some right axis deviation. You see lead 1 is negative and lead AVF is positive. So there is a evidence of right atrial enlargement, and right atrial enlargement is an indirect measurement of right ventricular hypertrophy. So also if you see there is a QR in lead 1, always see if there is a QR in V1, small q and tall r, it always suggests right atrial enlargement. So there is definitely a right ventricular hypertrophy and a right atrial enlargement. Now, apart from that, you can also see there is in lead V1, there is a negative terminal deflection, which suggests that there is a left atrial enlargement also. So this ECG suggests there is a biatrial enlargement. So there is a biatrial enlargement. There are various causes of biatrial enlargement, like the patient with multivalvular disease like MS, TR, TS, or second like a dilated cardiomyopathies where they can have, or sometimes infiltrative heart disease like amyloidosis and all. They can have biatrial enlargement. So these are the differential diagnosis of a biatrial enlargement. Now sometimes this biatrial enlargement will have low voltage complexes. In that case, you should always suspect amyloidosis type of diseases. If the biatrial enlargement has a normal voltage complex, then you should suspect dilated cardiomyopathy or a multivalvular heart disease. Now, so the learning points from this ECG is same ECG can have both by a P mitral and P tricuspidal, also known as P pulmonale. And if you see the QRS axis, normally in a patient with mitral stenosis, we say that this is a severe. So ECG also can tell you severe mitral stenosis. How? If the QRS axis is almost around the right axis deviation, it suggests that there is a significant pulmonary hypertension. So severe the right axis deviation, more, or if the right axis deviation is beyond plus 110, it means that there is a severe PAH. It means the mitral stenosis will be severe. So your ECG axis can tell you how severe is the mitral stenosis. A normal axis in a patient with mitral stenosis almost always rule out a severe mitral stenosis. Similarly, RVH or things like QR in V1 and right atrial enlargement all suggest to PAH. So if a patient has RVH, it means definitely there is a PAH. If QR in V1, it suggests that there is a right atrial enlargement, and all the right atrial enlargement are most often secondary to pulmonary hypertension. Now, again, seeing this ECG, a 30-year-old lady with chronic cough, now in heart failure. Now, we know that history can tell you this lady will have some form of ILD or the lung disease and now in heart failure. So, you have to suspect that there is a PH which has caused the right heart failure. Now, seeing this, you can see the axis. This is a sinus rhythm. Lead 1 is negative, AVF is positive. It means that there is a right axis deviation. Now, right axis deviation with QR in V1. Right axis deviation with QR in V1 means right atrial enlargement is there, and there is a P pulmon or a tricuspidal. So you can see that there is a tall positive P wave in means that there is a right atrial enlargement. Now right atrial enlargement plus some RVH feature means the patient has right heart failure because of the ILD or some sort of lung disease. So there are various criteria. I just want to show you this ECG so that it's easier for us to learn this criteria. Now this is a cyanotic infant. Now this is again a different thing. Till now we were discussing acyanotic heart disease. Now suddenly a cyanotic infant comes. Now whenever you have a cyanotic infant, your first diagnosis should always be things like tetralogy of Fallot. In an old age, if you get a cyanosis, your first diagnosis should be mostly a Eisenmenger syndrome. So TOF and Eisenmenger are the most two common differential diagnosis of a cyanosis, and the ECG looks almost always very similar in these two TOF. There are some few different catching points in TOF, which are one, you see there is axis. This is a sinus rhythm Q, and the axis is, you can see here S, you can see here R. So that it is a right axis deviation. So there is a right axis deviation, and then when you see there is a RBBB type of pattern, and suddenly there is a change in Q, a transition. So a sudden transition of R to S from V1 to V2 means there is a tetralogy of Fallot. This is one striking feature you just have to remember. But if you see a patient with Eisenmenger, all the Eisenmengers will have severe PAH. So they will have a different type of ECG. They will have a right axis deviation, RVH with strain pattern, which is not there here. QR in lead V1, which suggests that there is a pre-tricuspid shunt like a atrial septal defect. Here it is a different type of TOF. Though there is a RVH, you do not get a classical RVH in TOF. You get a right axis deviation and a RBBB in V1, which suddenly gets transition to V2. So this is a typical feature about a TOF ECG. Now, one more ECG is this, where you have a 28-year-old man with NYHA class 2 dyspnea. If you see again, it is a sinus rhythm, but the striking feature is P is very tall in lead 2. The P is very tall in lead 2 means P pulmonale is there. There is a right axis deviation as one is negative, AVF is positive. So a definite right axis deviation is there. If you see there is a Q and R in lead 1, it means there is a right atrial enlargement. The one of the important exception in this ECG is if somebody sees suddenly this negative deflection, they will tell that there is a left atrial enlargement also, which is not true in this case. And why? Because there is one important thing which is known as the pseudo left atrial enlargement sign, where if you see that there is a sharp sharp deflection in this P wave. Normally, a left atrial enlargement will have intrinsic or deflection. It won't be steep like this, whereas a right atrial enlargement will have a steep fall like this. That is one of the important differential between a right and a left atrial enlargement. So this is a right atrial enlargement, also known as a pseudo LAE sign. So this ECG only suggests that this patient has a RVH strain and right atrial enlargement. Now, this is mostly common. This type of ECGs are found in, if it is a non-congenital cyanotic heart disease, it is usually found in patients with some form of sometime a tricuspid stenosis and all, where there is a right atrial enlargement or a restrictive cardiomyopathy of the RV type or any RV cardiomyopathy in that sense. So the learning points I already told you. P pulmonale, you know how to distinguish P congenital or types of RVH. I will come into the some subsequent slides where there are different Chow classification of the types of RVH. There are three types. The classical one, which we have seen, where RVH with strain and QR in lead V1, where you see in cases only like pulmonary hypertension and pulmonary stenosis. That is type 1 RVH, which is a classical RVH. Type 2 is seen where you have an incomplete RBBB. Incomplete RBBB, you have to diagnose RVH. How? If the height of R wave is more than 15 mm, or if the R dash is more than 15 mm, or sometimes we say 11 mm, it is called a type 2. You see in conditions like ASD, patients with ASD. And type 3 RVH you see in patients with COPD. They do not have a classical RVH strain pattern, but they have a different morphology because of the RVH, because of the emphysema. There is an anatomical shift in the axis. So that is the class third type of RVH. We'll see in the further slides. Now the learning point is a steep negative in P in V1 can still be right atrial enlargement, as I showed you in this ECG. And the important thing is the onset to the nadir of P. If the duration is less than 30 millisecond or a steep fall or a steep inverted P, it is known as a pseudo left atrial enlargement sign due to a right atrial enlargement. Whereas a true left atrial enlargement is always with a slow slope. The slope is more than 30 millisecond. Now, let's go to the more theoretical type, where which you will be asked in your exam. So there are various criteria for right atrial enlargement, left atrial enlargement, and left ventricular enlargement and right ventricular hypertrophy. So let's see one by one. So in exam, the first thing they will ask you is, how do you know it is a RVH? Most of you will have, by now will know at least 3 to 4 criteria for RVH. There are actually 10 criteria for RVH. The important thing you should know. So the first thing which you always see is a tall R by S. So if the V1 is having a tall R, it means that first thing you have to suspect is RVH. Now there are almost 6 to 7 differential diagnoses of a tall R in V1. So not all tall R in V1 is because of the RVH, because there are other conditions, like sometimes if a patient presents with chest pain, it can be if posterior wall MI, or if you see that AVR is positive, there is a tall R in V1 and there is a reverse you say the progression of the R wave, then you know there is something known as a dextrocardia. In dextrocardia, AVR is positive and the P in AVR is positive, and you have a reverse progression of the R wave. So that is known as dextrocardia, where you can get a tall R in V1. There are other conditions like Duchenne's muscular dystrophy and Friedreich's ataxia, where you can have a tall R in V1. And then there are other conditions like, many other conditions can produce like a type B WPW or a left-sided WPW, which can cause a tall R in lead V1. However, important thing you should always rule out, or there can be sometimes a physiological variant where a V1 can have a tall R. So these are the various causes of tall R in V1, but the one of the things which you should keep in mind is a RVH. So to call it RVH, important thing is V1 R should be more than 7 millimeter in absence of a RBBB. If there is a presence of RBBB, it is always more than 15 mm. So in presence of RBBB, if you have to diagnose a RVH, you should see that the R dash or the tall R is more than 15 mm. Then there is something known as a QR in V1, as I already told you. A QR in V1 suggests a right atrial enlargement, which is almost secondary to right ventricular hypertrophy. So ratio of R by S in V1 should be more than 1, with R more than 0.5, and the ratio of R by S in lead V5, V6 should be less than 1. What is happening in V1 should be happening reverse in V6. S in V5 or V6 should be more than 0.7, And then this is one important thing. There should be a feature of right axis deviation. Right axis deviation is an important component of a right ventricular hypertrophy. Many people tell S1Q3T3. S1Q3T3, what we see in 10% of the patient with pulmonary embolism is actually a feature of RVH and not a feature of pulmonary embolism as such. Next is S1, S2, S3. All the limb lead V1, 2, 3. If all have an S pattern, then it is known as suggestive of a right ventricular hypertrophy. Then indirect measures like a P pulmonale, that is more than 2.5 mm in lead 2 and more than 1.5 mm in lead V1. So that is P pulmonale indirectly the right ventricular hypertrophy. As I already told you, in presence of RBB, the tallest R should be more than 15 mm to call it a RVH. There is some criteria known as the Cabrera index, which I won't go into the much. Now, what we use for LVH has similar criteria for RVH also, but the points are different. It is just for name. What I told you in the previous slide is something what you should remember. And then there is another Butler-Leggett formula for RVH. I won't go into detail because it is too much at the present. Now, important thing is the morphology. How various morphologies are there in RVH. You can get a right axis deviation. So based on the morphology, you can tell that there is a pressure overload or volume overload. Pressure overload you get in features such as pulmonary hypertension and pulmonary stenosis, whereas a volume overload you get in cases like a COPD, or you get in atrial septal defect, or a other conditions. So if you have a pressure overload, you will have a right axis deviation, you will have a tall R in V1 and a strain pattern in V1, V2, V3. Other things like a RBBB or a type 2 or type 3 type of RVH is not because of a pressure overload, but because of a volume overload. Now, as I discussed with you, there are various types of RVH based on which you can tell you the etiology of RVH. So a type A is the typical RVH where there is a tall R in V1 and the prominent S in V5, V6. There will be a strain pattern, and this you see typically in patients with pulmonary stenosis and pulmonary hypertension. Type B you see in patients with ASD where you have an incomplete RBBB and R in V1 will be more than 0.5 millivolt and R by S will be more than 1. Whereas a normal QRS in lead V5 and V6, V5 and V6 do not follow the typical criteria in type B. And type C you see in chronic lung disease like COPD and all, where it is due to the anatomical shift, you get a features of RVS. So you will have a small R and deep S in V1, V2 and a R by S ratio, RS pattern in V5, V6. So this is a typical case of a patient with COPD. You can see there is a small R and deep S in V1. There is a poor progression of R wave. But important thing is lead one sign. Lead one sign is very specific for patient with emphysema where there is a very small R, almost 1 mm or less in patient with COPD in limb lead 1. So that is known as lead one sign. So this is one of the important features of patients with COPD. Now again, let's discuss one more ECG. This is a ECG of a 4-month-old baby with heart failure and that for a duration of 1 month. Now again, if you see this ECG, you have a ECG with sinus rhythm, but what is known as this P waves are known as Himalayan P waves. This P is almost equal to QRS. So a P wave which is almost same as QRS is known as the Himalayan P waves. And if you see here, the P wave along with the P, there is right atrial, there is also a left atrial enlargement because there is not a steep but a slow slope. So there is a right atrial enlargement and the left atrial enlargement. So a 4-month-old baby with heart failure with biatrial enlargement, 3 things you have to keep in mind: cardiomyopathies, valvular thing, which is very unlikely at this age, and third is infiltrative diseases like amyloidosis and all. So let's see. So what are the main findings of this ECG? Tall P wave suggestive of right atrial enlargement, widened in negative P waves, as I told you in lead V1, which is suggestive of a left atrial enlargement, and a normal QRS voltage. So what can it suggest? A biatrial enlargement can be due to biventricular dysfunction, restrictive cardiomyopathy, and multivalvular disease, as I told you. If there is a low voltage QRS, it is suggestive of infiltrative disease like amyloidosis. If there is a preserved QRS voltage, then it can be either a dilated cardiomyopathy, multivalvular diseases, or other RCM non-amyloidosis related. So these are the things which you should always keep in mind in a patient with biatrial enlargement and other things. So let's discuss what are the criteria for right atrial enlargement. By now, I have told you all the major criteria. Let's brush up once again. So first important thing is P pulmonale. In lead 2, limb lead 2, if the height of P is more than 2.5 mm, or in lead V1, the height of P should be more than 1.5 mm. As I already told you, there is something known as the yeah, the increased area under the initial portion of V1, which should be more than 0.06, that is not important, but a rightward shift of P wave axis. Most of the time, we are not able to know the axis of P wave. So we indirectly tell the axis of QRS, because axis of QRS and P wave go simultaneously. But the most important criteria is the QR, which I am telling again and again. Small q, tall r in V1 suggests right atrial enlargement, and that is 100% specific for right atrial enlargement. Next is low amplitude QRS in lead 1. Suppose a lead V1 has low amplitude QRS and there is sudden increase in the QRS in lead V2. That is a threefold rise. Then it is more very specific for right atrial enlargement. So if you see a pseudo left atrial enlargement sign like this, like a prominent terminal negativity in lead V1 with a steep slope, but you see that a QRS voltage suddenly from 0.3 or 0.4 mm became 1 to 1.2 mm. It means it is very specific for right atrial enlargement. And finally, a terminal negativity in lead V1 is again a sign of right atrial enlargement. So at least 3 to 4 sign, if you remember, it is more than enough of right atrial enlargement. Now, what are the various causes of right atrial enlargement? We can have a valvular heart disease like a tricuspid stenosis and tricuspid regurgitation. All the pulmonary hypertension, when they develop RV failure, like patient with ILD, COPD, mitral stenosis, they will have right atrial enlargement. It's not like all the patient will have, but if they develop significant RVH and RV failure, then they will develop or right atrial enlargement. Congenital heart diseases like a pulmonary stenosis, tetralogy of Fallot, and Epstein's anomalies can cause right atrial enlargement, and it can be transient in patients with pulmonary embolism or status asthmaticus. So these are the various causes of right atrial enlargement which you should know. Now, as we were discussing, what are the important points for left atrial enlargement? First, in lead 2, you should see that the P wave duration should be more than 120 millisecond. And as I told you, also if they have bifid P wave, you should see that between the two notching, the duration should be more than 40 millisecond between the two notching. Next comes the Makruch index in lead 2. So the ratio of P wave duration, you can see this is the Makruch index, because once the P wave duration become more than 120, the PR, the from BC point, so the ratio of AB to BC, that is the P wave duration divided by PR segment, should be more than 1.6. So the P wave duration will invariably most, if it is a severe left atrial enlargement, becomes more than 120 millisecond, and this PR becomes very less. So this duration divided by this interval becomes more than 1.6. It is very specific for left atrial enlargement. Similarly, Morris index is the uh, multiplication of AB. So the duration of this P wave into the height of this P wave. So if the duration into height is more than 0.04, it is suggestive of left atrial enlargement. Normally, this ratio should be less than or equal to 0.04. If it is more than equal to 0.04, so the duration of P wave divided by the height of terminal reflectivity in V1. If it is more than 0.04, it is known as the Morris index. So this is something which is important. Since this 5 points, if you remember, it's more than enough for a left atrial enlargement. So what are the various causes of left atrial enlargement? Is again valvular heart disease, and the most common valvular heart disease to cause left atrial enlargement is mitral stenosis. Second most common will be a mitral regurgitation. Third will be aortic valve diseases. Then we have hypertensive heart diseases which can cause, and cardiomyopathy like a dilated cardiomyopathy or a hypertrophic cardiomyopathy which can cause left atrial enlargement. Now let's go to the various criteria for LVH. This is the most common thing which you will be seeing in your day-to-day practice. It's not the RAE or LAE, it's the LVH. And most of you will be confused. Many of you, when asked in exam, may not be able to tell. And most of you will tell the Sokolow-Lyon. The most common criteria which you will be using is the Sokolow-Lyon criteria, where you see that the height of S in V1 plus R in V5 or V6, if it is more than 35 mm, we say that it is LVH. So that is the most common criteria which all of us know, because, but it is not bad, because this is most commonly used. So if it is a S in V1, not the V2, S in V1 plus R in V5 and V6 more than 35 mm, which tells that there is a LVH. Also, if one lead here, you have to see in Sokolo lion, it is AVL. So if lead AVL is more than 11 mm, it can still tell that there is a LVH. So one of this should be hold true. So you can see that AVL is more, and here S in V1 and R in V5 or V6 is more than. So Sokololoyan doesn't have much high sensitivity or specificity. There should be a criteria which is high sensitive, and there should be a criteria which is high specific. So the most sensitive criteria for LVH in ECG is a cornel voltage criteria. So you see in the cornel voltage criteria, you have to see the R wave in AVL and the S wave in lead V3. The sum of R wave in AVL and S in lead V3. If the sum is more than 28 in males and 20 in females, then it has the highest sensitivity for diagnosing LVH. So if you see in V3, the sum of S and the sum of R in AVL, if it is more than 28 in males and 20 in females, then it is definitely a high sensitive for diagnosing a LVH. That is the cornel voltage criteria. I won't go to the modified cornel, where it told that if you see the R in AVL, if it is more than 12 mm, it is suggestive of a LVH, which is like the Sokolo lion. Now, which criteria has the highest specificity for LVH is the Romhild-Estes criteria, where it has 5 different points. If you have a point which is more than equal to 5, then LVH has a high specificity up to 97% for diagnosing LVH, but it has 5 points. So what are those 5 points? You see the limb leads. In limb leads, if any of the limb lead is more than 20 millimeter, then you get 3 points. If in precordial lead, if V1 or V2 or V5 or V6 has 30 mm, any of this lead has 30 mm, then again it will have 3 points. Now the ST changes, which is known as the overload. STT changes opposite to the, that is the we say LVH with strain. If strain pattern is there in patient taking digoxin, then we get 1 point, and without digoxin we get 3 points. If there is a left axis deviation, you get 2 points. If there is a left atrial enlargement, you get 3 points. QRS duration more than 90 has 1 point, and the intrinsicoid deflection in V5 or V6 has 1 point. So if 5 or more points are there, it is almost 97% specific for LVH. Let's see this ECG. If you see this ECG, you have almost this, you can see V1 or V2. V2 has almost 30 mm, 5, 10, 15, 20, 25, almost 28 mm. But you see that there is a left axis deviation, 1 and AVF. And you see that there is no very typical left atrial enlargement, but there is some evidence of left atrial. But there is a overload pattern. If this patient is not on digital, it has 3 points, and left axis deviation has 2 points. So it made 5 points for your left ventricular hypertrophy. So Romhild-Estes is a criteria which you should all know. Sometimes they ask what is the total QRS duration to call it a LVH. So if you see all the precordial lead, if you just do the sum of all the QRS voltage, if it is more than 175 mm, it is suggestive of LVH. Sometimes they will ask you how do you diagnose LVH in excuse me, just 1 second. Hello. Yeah. So if you see that in, yeah. So in presence of LBBB, if somebody asks you to diagnose LVH, it may not be very difficult, but it may not be very easy. So in that case, you should always see the R in AVL. If the R in AVL is more than 11 mm, it is very specific for diagnosing LVH in presence of LBBB. The QRS voltage, when you see, it is not the 35 mm what we say. It should be more than 40 mm. That is S in V2 more than equal to R in V1. So it should be more than 40 mm, a single lead. Or S in V1 or R in V5 or V6 should be more than 40 mm. So if you see the S in V1 or the R in V5 or V6, it's not 35 mm, it should be 40 mm. Or the S in lead V2 should be more than 30 mm and S in lead V3 should be more than 25 mm. So the criteria is little higher when you have to diagnose in presence of LBBB, the LVH. Similarly, in the presence of RBBB, it is very difficult to diagnose LVH. However, again, some criteria are there, like the maximum R and S in precordial lead with left axis deviation. So in RBBB, if you get a left axis deviation, you should always suspect the presence of a LVH. So a left axis deviation in presence of RBBB should always suspect LVH, and the criteria should be met, like maximum R or S in precordial lead should be more than 25 9 mm. If you see a S in lead V1, in presence of RBBB also, if you see a S in V1 which is around more than 2 mm, you should suspect that there is a LVH, or a R in V5 which in RBBB you do not get a R, you get a inverted M in V5 V6. But if you get a R in V5 which is a V6 which is more than 15 mm, again it suggests the LVH in presence of RBBB. So these are the some of the important points which tell that how do you diagnose presence of LVH. Now again, similarly, there is a newer criteria. I don't want to go into data, but you should just remember that there was a criteria which had come in 2017 where the deepest S plus the S in lead V4, S in lead V4. So the deepest S, whatever is the deepest S, like here in lead V2, the deepest S, or the S in lead V4 should be more than 23 in women and 28 in male. Then it suggests that there is an underlying LVH. Until now, this has the most accurate and high specificity for diagnosing LVH. Now, there are the various causes of LVH, like the pressure overload. We know there is an systemic hypertension in patient with aortic stenosis, hypertrophic cardiomyopathy. We get LVH, and some causes of volume overload, like in patient with mitral regurgitation, aortic regurgitation, and dilated cardiomyopathy. How do you distinguish pressure and volume overload? Is in pressure overload you get strain pattern, in volume overload you don't. You get deep Q wave in V5 V6 in volume overload, whereas in pressure overload due to septal fibrosis you do not get a Q wave in V5 V6. You get a tall T wave in V5 V6, positive tall T waves in V5 V6. In volume overload you get inverted strain pattern in pressure overload. So these are some of the difference you should know to distinguish between a pressure and a volume overload. So I would like to conclude here.